everyone for your time and attention. And I'll be focusing on next 15 minutes about the novel therapeutic agents and our current treatment algorithm. This was the same presentation I used at PVRI. These are my disclosures, and let's talk about the management of PAH. And whenever we talk about treatment for pulmonary hypertension, of course, survival always comes into the picture. And this is just a two Kaplan-Meier curve showing you the survival about the pulmonary arterial hypertension from the NIH registry and the REVEAL registry. Clearly, the top curve shows better survival over a period of time. However, it is still suboptimal, and that's why there is a lot of stress about finding newer therapeutic agents to improve the survival in pulmonary arterial hypertension. And this is a slide just briefly talking about the progression of disease, what happens in PAH. And as you can see, this is just I can use analogy like a life cycle of PAH, and you slowly see the pulmonary vasculature or the resistance vessels in the pulmonary vascular bed starts to get thickened and narrowed. And as it progresses, it increases the afterload for right ventricle. Right ventricle starts to develop dysfunction and eventually fails. And you can see in the center of the slide how the hemodynamic parameters change over a period of time. And then why does it happen? There are as we know, PH is a multifactorial disease, and there are multiple mechanisms involved. But the bottom line is there is a balance of anti-proliferative and the proliferative mechanisms, and that leads to these changes in the smooth muscles of the pulmonary arteries. This is a slide highlighting now the 4 different pathways which we have available for the treatment of PH. And as I highlighted, a paradigm shift because now last year we had another fourth pathway approved for the treatment of pulmonary arterial hypertension, and it works in a slightly different way. It believed to cause what we call as make anti-proliferative. It does not primarily work on a vasodilatory pathway or mechanism. On the right side, however, the 3 traditional pathways, which all of these drugs do have some anti-proliferative properties as well, but primarily act by causing vasodilatation as well. So the right side is of the slide. You could see the 3 traditional pathway: endothelin pathway, nitric oxide, and prostacyclin. And on the left side of the slide, we have activin signaling inhibition, which is the recent addition to our armamentarium for the PH treatment. See. Why I'm not able to move. Okay. So briefly talking about how the Sotatercept work. And again, as I previously highlighted, that in the disease, there is an imbalance between the pro-proliferative and anti-proliferative mechanism. And what Sotatercept does is it tries to rebalance that the way it works. As you can see on the right side, this is the smooth muscle cell where you have these activin a receptor ligand trap, which is highlighted here with the Sotatercept, and it kind of blocks this signaling and it decreases the pro-proliferation signaling. It also modulates the BMP, which is the anti-proliferative signal, but predominantly it's an activin ligand trap, so it kind of decreases the pro-proliferative signaling in the smooth muscles. So on the clinical side, the drug got approval based on this pivotal trial, which was a STELLAR study. I think most of the clinician researchers and even the patients are familiar with this main trial. In the phase 3, this drug showed significant benefit in PAH. Just going over what the demographics were, as you can see, because it was a randomized, controlled, placebo-controlled trial, so a global study. It had 323 patients total and female predominant. The one thing to highlight that the trial had very prevalent patient population. As you can see, majority of patients were on triple or dual therapy. As you can see, 60% patients were on triple therapy, and almost 35% patients were on dual therapy. And almost 40% patients were on parenteral prostacyclin. Just showing you the primary endpoint of the trial, which was the 6-minute walk distance. And clearly, I think anyone can assess that there is a very significant improvement in 6-minute walk distance in patients who received Sotatercept compared to placebo. Although study was not designed for this, but they also observed pretty significant improvement in the morbidity events, or you can say fatal or non-fatal clinical worsening events, much less in the patients who were on Sotatercept compared to those who were on placebo. So the drug actually showed a pretty all-round performance. It also improved the quality of life questionnaire also, and there were a bunch of other secondary endpoints apart from the hemodynamics. The echo parameters and everything also improved in patients who were on Sotatercept. As I always say, nothing comes without a baggage. So all the drugs, this also had some side effects. And one of the main one which kind of caught our attention after the trial were the bleeding side effects. Some patients noticed some bleeding episodes. Majority of them were trivial nosebleeds, but some patients had some GI bleeds as well. Then the platelet count also was noticed, and also the increase in hemoglobin was noticed. One unexpected finding was development of telangiectasias, which we learned after the PULSAR study, and we observed that in this study also. And as you can see here, I'm highlighting those main side effects which we observe with Sotatercept. And as you know, in the United States, when the FDA approved the drug for the first 5 doses, we are required to monitor hemoglobin and platelet counts in these patients. This is just showing impact on the hemodynamics. Although drug improved the mean pulmonary artery pressure, but interestingly, the way it works, we did not observe much change in the cardiac output and cardiac index, and it's sort of still, I would say, a little bit of a mystery. There are multiple hypotheses. It's probably hypothesis generating finding, and there are multiple thoughts behind it, why it is. But again, we clearly are not entirely sure the reason why we did not observe that. But regardless, the mean pulmonary artery pressure dropped pretty significantly. PVR improved pretty significantly in these patients. And this is a paper which recently got published because this was one thing, because traditionally we observe improvement in cardiac output with response to the treatment in PAH. And so there was this question whether the drug is effective in patients who have less cardiac output or cardiac index to begin with. And actually, it did show pretty significant improvement in those patients as well who had less cardiac index or cardiac output to begin with. Their 6-minute walk distance, as you can see, improved dramatically, PVR improvement and improvement in NT-proBNP. So across the board, it showed improvement regardless of the cardiac output at baseline. This slide just highlights the changes in the echocardiogram. And as I mentioned earlier, most of the echocardiographic parameters also improved in this patient population who were on Sotatercept. This is long-term. SOTERIA is an ongoing long-term study of Sotatercept. And as you can see, the effect was still sustained at 1-year mark from the beginning of the SOTERIA study, which is 24 weeks after the main randomized control study. So roughly 1.5 years, you can still see the patients were improving to low risk, and they were maintaining their functional class status and sustained improvement in NT-proBNP. So if we look at, to summarize all these findings, yes, there was improvement in the functional capacity, functional class improved, mean PAP and PVR improved without a change in the cardiac output. There was some evidence to reduce the risk of clinical worsening events and improvement in patient-reported outcomes as well. On the imaging side, there was improvement in the RV size and mass. If you look at the side effects, there was hemoglobin increase. In PH patients, I feel like that's somewhat beneficial just because they generally tend to be anemic. perhaps beneficial in those patients, but of course they need to be monitored for a drop in platelets and the bleeding events. And telangiectasia is something we are observing, and I think we will need more data on this to learn how this really pans out and what is going to be the long-term implication of these telangiectasias. As of now, we do not know much about these. And then some other side effects were observed, like headache, rash, and diarrhea. So overall, fairly well tolerated drug with very much all-around improvement in the patients. Now, this is where we'll start talking about how we think that Sotatercept is going to impact our treatment algorithm, and this is just more hypothesis generating. On the top part of the slide, you would see what we tried to, in this manuscript we published earlier this year, tried to show how our traditional treatment is and how it will be impacted with the Sotatercept. As you can see, if the patient is on intermediate risk, you could start with the 0.1 dual therapy. Then patient improves, regular follow-up, risk assessment. If they improve to low risk, great, you continue follow-up. But then again, as the disease progresses, they start falling towards intermediate to high risk. Then you add prostacyclin or prostacyclin analogs, they improve. Then again, parenteral prostacyclin, and then eventually disease progresses, transplant or palliative care. That's our traditional. How we are thinking that how Sotatercept is going to sort of help your patient. It's similar, dual therapy improves, again, get worse. At number 3 here, you could consider adding Sotatercept. That's the earliest evidence we have that you could start Sotatercept on a patient. And then patient improves. Now, the number 4 is some durability or the sustained effect. We have data for a year or two after the randomized control study that patients have sustained effect. We're going to learn more from the long-term Soteria study as more manuscripts come out from Soteria, that how long this durability of effect will be, but you can see it clearly can impact the survival and prolong the survival. And then again, as the disease progresses, at number 5, you can add prostacyclin, and then you could see how patient respond and transition. And if things still do not work out, maybe transplant or palliative care. But again, for number 5 and number 6, we do not know when that time will arrive in a natural progression of the disease. If we start Sotatercept earlier in these patients, we were a little unsure at this time, but this was more for what we thought could be the impact on the treatment and the survival. Now, I'm going to show you 2 algorithms in the next 2 slides. This is what we published last year, like a US perspective, where we believe that Sotatercept can be earliest instituted in the treatment paradigm and how this may impact. And as you know, that the treatment in PH is risk based, and you do a baseline risk assessment, low, intermediate, and high risk, and then you proceed with starting the treatment. If your patient is low and intermediate risk, then you start on dual therapy. And then if they remain in low risk, you continue dual therapy. If they become intermediate low risk or intermediate high risk, how you would proceed with adding further agents. And those are the earliest positions where you can start activin signaling inhibition or additional oral prostacyclin agent or inhaled prostacyclin agent. The 2 things which I would really like to highlight here, which was we took a little bit of different approach. We put shared decision making with the patient in the center of all the decision making, that whenever we have any treatment options we added, it should be a discussion between physician and the patient to know what their expectations are, what their lifestyles are, what they are looking for. And then we consider adding what would be the right medication for your patient. The other approach, which was a little bit more expert opinion and currently not very well supported by the evidence, is that even if you are low risk, but if your echo doesn't look good and your RV is looking bad, we suggested that we can consider adding a therapy. Again, this is something more expert opinion rather than evidence-based at this time. Now, if we look at the high-risk patient who we suggest that apart from the oral combination, you add parenteral prostacyclin and then do a reassessment at 3 months. And if you see that they have achieved the low risk, then you follow the low risk approach. If they are in intermediate risk or high risk, while they are on prostacyclin, you may consider adding activin signaling inhibition. And if they still remain in high risk at 3 months reassessment, you definitely consider activin signaling inhibition and refer for transplant. The two difference between the intermediate or the high risk were consider lung transplant or refer for lung transplant. We were just being more, I would say, uh, uh, emphatic about sending patients for lung transplant if they remain in high risk at 3 month interval. This was from the World Symposium. Again, a very similar approach. However, in this one, the main change from the prior algorithms were that at baseline, we kind of categorize the low and intermediate into not high-risk patients versus high risk. But the treatment recommendations are very similar to what we previously discussed in the previous one. But certain things to keep it in mind, which were highlighted in this algorithm, that most of the drug trials or the prior drugs which were done with the older definition of mean pulmonary artery pressure of 25 and the PVR of 3 Wood unit. We talk about risk assessment, but we also mentioned that hemodynamics, RV imaging, and other measures should be taken into account when you're advancing the treatment. Initial triple therapy for high-risk patient is recommended in high-risk patient, but may be considered in some non-high-risk patient where the hemodynamics is bad or the RV function is poor. And again, we talk about risk assessment and risk-based treatment, but keep it in mind, there will be many patients where the low risk will not be possible. And there could be majority of reasons, not just their RV is bad, but they are older, they're frail, they just cannot walk for 40 meters, their autoimmune condition, they are obese, their systemic diseases may preclude them to achieve the low risk status. And in those cases, the treatment should be tailored according to the patient needs. Then let's talk about some drugs in the pipeline which are showing some promising result, and seralutinib is one of those. It's a platelet-derived growth factor inhibitor, but it also has some anti-inflammatory proliferative properties through c-KIT and CSF1 blockages in the macrophages. This is an inhaled drug which is twice daily, and in phase 2, it met the primary endpoint of hemodynamic improvement. And this was a paper published in Lancet, and currently the phase 3 study is ongoing, and very much likely that hopefully soon we will have the results of the phase 3 data. This is one more thing I wanted to highlight, at least in the United States. I'm not entirely sure if it's available in the Europe as well or not, but there was a combination pill now that you could use tadalafil and macitentan combination pill. This was a study published last year, which showed that the combination pill was equally effective in dropping the PVR in these patients. And so now it's just to reduce the pill burden for patient, and it was fairly safe and well tolerated by the patients. I would like to highlight this manuscript which came out, I think, last month. It was a global work with the disease expert along with the regulatory bodies and the patient representative. We published this in Lancet. It was more of a personal viewpoint. What should be our future paradigm for treatment should be. We started, of course, we know the natural progression of the disease is that it progresses. We initially focused on, with some trials for initial drugs, slowing the decline, focusing on the morbidity, mortality event. Then we started talking about disease improvement. And then we started talking about how about introducing the concept of remission, where patient takes the medication but stays in remission and no flares of the disease. Now, how would you define the remission? And this is, of course, this needs to be validated. This is the proposed table where we are talking about what could a cure in PH may look like, what the complete remission may look like, and what the partial remission may look like. And we took into account, again, this is based on the scientific data, but then experts sort of weighed in that what we believe should be a complete remission or partial remission may look like. And then improvement in hemodynamics. We took into the imaging criteria, mortality risk based on the risk and the disease, pH-related symptomatic burden, what their functional capacity is, and then what their disease course would look like if they achieve the complete remission. Again, this is more for, as I said, for future research and hypothesis generating, but I think that's where our discussion should go on here onwards. So overall, as we know, PH is incurable disease, and Sotatercept is definitely a welcome addition. The possibility of reverse remodeling, I think currently we do not have enough to really say how the drug works and exactly what is the best technique to prove that. We are also watching carefully the durability of effect with the newer therapeutic. We do not know any future long-term use drug side effects. And as I highlighted, many new pathways are being explored. With that, I would like to end my presentation. Thank you. I'm going to stop sharing my slide and I'm open for any questions. Thank you.
Great. Thank you so much, Dr. Sai. We do have a few questions. Great presentation. Can you talk about the potential in HDAC inhibition, Serino CS1 for future PAH treatment? Thank you. Just put that.
Yes, I think, thank you for that question. Again, like many other drugs, this is another molecule which is being investigated currently. And I saw there some early reports, some beneficial data, but those were small open label studies. I think they are moving towards their phase 2 and 3, and then we will see how that works out. I think at this point in time, I do not have more information on that, but it did show some early promising results in that.
Great, thanks. And yeah, we have Matt Granado here in the backstage ready to do the next presentation. But first, let's ask another question. Do we have any way of anticipating, I'll put it in the bottom of the chat now, the theoretical effects of using Sotatercept with other new pathway drugs such as seralutamab? Sorry for the bad pronunciation.
Okay, so it's a very interesting question. So first of all, in the real world, seralutinib is still investigational and Sotatercept is approved. However, now in the phase 3 trial, we are including some patients who are on dual therapy. So of course, with time, we will know once the seralutinib trial is completed. There was an abstract presented, which was more focused on the basic science. And it actually showed abstract presented at PVRI, which actually showed there is some synergistic effect of Sotatercept and seralutinib in the animal model. I do not have access to that right now, but I think that's something in clinical arena will take a little bit more time for us to know. But I think there is some theoretical concept that, yes, there is some synergism between the two drugs.
Sorry, I was muted. Maybe one last one. I promise, last one.
Sure.
Are there any reliable alternatives to right heart catheterization and diagnostics and assessing the progress? Can echo replace it at this stage?
So again, it depends on the practice at different places, how people practice. I mean, many people rely on cardiac MRIs a lot, and now, especially the way Sotatercept trial was conducted, we have a pretty good imaging data also available from the echo. For diagnosis, right heart cath is still considered as a gold standard, or you could say it's still confirmatory. However, in future, if cardiac MRI is going to replace it, I cannot say that. But again, there is no a big, large study to really support that head to head with a right heart cath. But there is definite some some really exciting data on cardiac imaging is there, including the right heart, including the cardiac MRI. We use echocardiography in routine follow-up, but not as a diagnosis, but it's an excellent screening tool for pulmonary hypertension, and it is still recommended by the guidelines as a screening tool. I think someone is asking about cardio-MEMS. Cardio-MEMS has definitely helped in certain patients as we are using, but it's still not very widespread being used in PH. But again, it all depends on the practice you are in and the patient profile you are looking at. I have few of my patients on cardio-MEMS, but it's I think it's that we are learning more from the heart failure patients that it can be utilized, and I've been using in certain patients where I feel repeated right heart catheterization is not feasible or not easy for a variety of factors, or the echoes can be challenging, or I need close monitoring on certain patients. So certainly there is a role for this to be done. As someone mentioned earlier, I think that CS1 trial is also using cardio-MEMS in their study. So perhaps that will tell us more about how it can be utilized in PH clinical trials as well.
Thank you, Dr. Sahay, and thank you again for sharing your expertise with the patient community here through the Alliance for PH, and wish you a really great rest of your day there. And yeah, look forward to the next discussion with you. Always learn a lot, a lot.